Hello and welcome everyone to this afternoon's Ask the Expert webinar. A few of you sent me some questions beforehand and I said that we might be starting a little bit late because Dr. Quraishi had to attend an urgent meeting, but he did come on time, so we're delighted with that. And I hope that the people that I said we are going to start late are here for the start of the session. My name is Paula Hanford. I'm the CEO of PSC Support. And I am delighted to be joined this afternoon by Dr. Nabil Quraishi. Dr. Quraishi is a consultant gastroenterologist, an IBD specialist at the University Hospital Birmingham. Dr. Quraishi is the chief investigator of the PSC Vancomycin study. And this session is mainly about PSC and Vancomycin and what the study has found so far. As always, I'm sure you will join me in thanking Dr. Quraishi for giving up his time today and joining us. And yeah, thank you so much, Dr. Quraishi, for that. Please feel free to ask your questions in the comment section. And please try and keep the questions as short as possible so we can get through as many as possible. I have had 10 questions sent to me before this webinar, so I will try and get to as many questions as I possibly can. I know this is a really popular and interesting subject for patients with PSC. As always on these sorts of events, Dr. Quraishi cannot offer individual medical advice, but will answer your questions as best as he possibly can. So welcome, Dr. Quraishi. Thank you so much for giving up your time this afternoon. We are really grateful. If you could give us a brief overview of the subject, and then we will take some questions.
Great. No, thanks very much. Thanks for the invitation. I think this is quite a very interesting area, something that we've been interested in over in Birmingham for a while. So just a few disclaimers. I mean, I'm not a liver doctor. I'm a luminal doctor. So that means I deal with the inflammatory bowel disease side of PSC. So I know Dr. Trivedi has been on previously to talk about the PSC side of things. So I'm quite interested in the luminal side of PSC. Then the question is, does PSC start in the gut? Who knows? Maybe not. And that's a lot of the research that I've been doing for the last 10 years. Previously with Gideon Hirschfield, when he was here in Birmingham, was trying to understand the basis for PSC in the bowel, and whether it's a microbiome derived event or whether there are any other factors that play a role. So I can give a brief overview of the study so far, I think, but I'm keen to keep this as interactive as possible because this will raise a lot more questions than give answers, hopefully, and then we can discuss about how we go ahead with taking this data further. So I'm going to try and share my screen. Hey, don't know if you can see that. If you can, let me know. You can see that? Okay,
yeah,
great.
We can see it.
So everyone probably already knows and seen these slides a few times, but the reason why I find the IBD in PSC interesting is because it behaves very different to standard IBD. It's not, if you know patients with standard ulcerative colitis who don't have PSC, you'll note that their IBD behaves very differently. So they may often have very aggressive forms of colitis, for example. They are not at greater risk of bowel cancer, and their colitis, it behaves very differently in the bowel. So it's usually starts in the rectum and goes all the way around. Whereas the colitis that you get in PSC is very different. It's often very patchy. It is more the right colon looks more inflamed, but often patients don't get many symptoms. So you'll see patients who are completely asymptomatic, but when you put a camera inside, it's very inflamed. So there's always that discrepancy between symptoms and what the disease inside looks like. And also, that the risk of colon cancer is slightly higher in patients with PSC compared to patients who don't have PSC. So by all intents and purposes, it is a different disease. The colitis that you get in PSC, we treat it the same as ulcerative colitis because it responds to the same medicines we give patients with ulcerative colitis. But I think our reasoning is thinking, and so is our terminology. We don't call this ulcerative colitis or Crohn's disease anymore. We call this PSC IBD because of the way it behaves, and so that we can try to understand these differences from mechanistic basis. So some of the work that we did before, let me just share my screen. Actually, I might be able to do this properly. Let's stop share. Okay, some of the work we've done before to try to understand what makes PSC IBD different from standard IBD is looking at gut bacteria, because we know that gut bacteria is different in patients with IBD, and we've also demonstrated that gut bacteria in patients with PSC IBD is also different. And that's also been demonstrated by quite a few other groups across the world. So not only is the disease behaving differently, the genetic basis for the disease is different, but also the gut bacteria appears to be different compared to standard IBD. So it's a different disease. So, the question is, does this mean anything? Is this just something that we see because you got liver disease and you've got difference in your gut bacteria because you've got difference in bile acids flowing out of your liver? Or does the disease start in the gut, and do the gut bacteria have a role to play in the disease? So what we did was we did a lot of work in trying to understand the mucosal basis for PSC IBD, and we took samples. This is before the vancomycin study. We took samples from patients with PSC IBD and standard colitis to see what the differences are at the level of the bowel. And we found that the immune signals are similar, but the gene expression or the way the colon is behaving is very different in the number of genes and the types of genes that are being expressed. And the questions came around, is this a bile acid mediated disease? Is there something going on in the bowel that means the way you metabolize bile acids in your bowel are different if you have PSC IBD compared to ulcerative colitis? And maybe there may be a mechanism associated with both the colonic disease that you get in PSC associated with bile acid homeostasis, as well as in the liver. And again, that's an entirely different topic, but there are differences. The gist is there are mucosal differences in PSC IBD that may hint towards the mechanisms of disease that both happen in the colon as well as in the liver. So I'm going to skip that. One possible mechanism is that you've got overload of bile acids in the gut, and bile acids generally are toxic. So if you have a lot of bile acids, they cause inflammation in the bowel. And the inflammation we're seeing in colitis that you get in PSC IBD may be related to a buildup of bile acids. And so maybe blocking bile acid uptake may be a form of treatment, and there are lots of treatments being explored along that pathways. So one way of understanding whether this works is to try and change your bacteria. So if you think your gut bacteria is associated with PSC IBD and maybe PSC, well, change it and see what happens to the disease. So both in the gut as well as in the liver. So we saw, well, vancomycin seems to be very popular. We don't use it that much in the UK, but it seems to be used widely for reasons unclear across Europe and in the US. And there have been a few studies, very small studies, showing that vancomycin appears to improve liver enzymes, not liver outcomes, but liver enzymes if you use vancomycin. And also there have been a couple of studies, again, a small number of patients, so 8 patients, which showed that vancomycin does improve your PSC IBD in patients with active IBD. So there is probably some role with vancomycin. What's interesting about vancomycin, unlike other antibiotics, is that oral vancomycin gets very minimally absorbed. So the oral antibiotic that you take works in the gut, and you get very little systemic effects. So whatever's happening in the gut, whatever's happening with oral vancomycin appears to be a mechanism that's isolated to the gut as opposed to systemically, because it doesn't get absorbed. And vancomycin, being an antibiotic, does change gut bacteria. So the question is vancomycin working by changing your gut bacteria? And that's one of the questions we went on to ask in the study. So this study was funded a couple of years ago. So just around COVID time, we got funding to do a 15-patient study where we gave 15 patients with active PSC IBD 4 weeks of oral vancomycin. We collected stool samples at multiple time points, so at baseline, 2 weeks, 4 weeks, and 8 weeks. And we did a colonoscopy at baseline, and then a mini colonoscopy, so sigmoidoscopy 4 weeks after. So we wanted to see what was happening to your gut bacteria, how the gut bacteria were functioning. So we're looking at functional metagenomics or metatranscriptomics. We're trying to understand what happens to your bile acids in your gut. So, do your bile acids change? And again, if the bile acid hypothesis holds true, then you'd expect to see a change in the bile acids that is associated with improvement in disease. But we also wanted to know all those pathways that are showed in the gut associated with bile acid homeostasis, whether they change. So, which is why we need to take mucosal biopsies. And we're going to put all that together to try to understand whether you can get a clearer picture as to what happens in PSC IBD and what vancomycin does to these mechanisms in PSC IBD. So we completed the study last year, end of last year, and we've got most of the data. A lot of the data is still being processed currently because it's a mechanistically very heavy study. And I think a few of your participants may have taken part in this study. So 15 patients took part in this study. Being a male predominant disease, again, you'd see approximately 75% of the cohort was male. All of them had UC, so isolated colonic disease, with a moderately elevated fecal calprotectin, which is a biomarker of inflammation in the gut. A lot of them had moderate to severe disease. A lot of them were exposed to biologics before. So this is your standard PSC IBD cohort that you'd see in clinic. A few of them had liver transplants, but all of them had recurrent PSC if they had liver transplants. So they had active liver disease from a PSC point of view, but all of them had active, moderate to severely active PSC IBD. A lot of them were refractory to biologics and were being worked up to switch a biologic or were pre-colectomy. So fairly advanced colonic disease at this point. But what we see here is this is fecal calprotectin. So the higher the fecal calprotectin, the more severe your disease. What you have at the bottom is your time points. So you got baseline, week 4, so 4 weeks of treatment. And then we repeated the fecal calprotectin after a 4-week washout from vancomycin. So what we see here is your fecal calprotectin, and pretty much everyone drops down to not a normal range. So a range where we'd call them to be in biochemical remission. So it was a remarkable effect that we saw, except for one patient who needed a bit longer on that vancomycin after that washout period to get them better. So a lot of them started pretty high, and then everyone went into clinical remission, and most of them went into biochemical remission. But in some of these patients, you see after the 4-week washout period, so 4 weeks off vancomycin, so after completion of vancomycin, they started to relapse again. So their disease and inflammatory burden started to come back. Partial Mayo is a score that we use. It's a score that's commonly used to understand disease clinical outcomes in patients with colitis. It's basically a symptom score that takes into account your bowel frequency, how much blood you've got in your stool, and a global assessment made by the physician. And what you see in the partial Mayo score is, again, there's a reduction. And most patients have a clinical response or enter clinical remission. And again, that appears to go up in the washout period. So after they complete vancomycin, if you leave it another 4 weeks, their disease appears to come back. And we see the same thing with the endoscopic score. The endoscopic score appears to go pretty close to normal in all these patients. Okay. And I'm looking at the liver enzymes, and we weren't looking at the liver enzyme necessarily as part of the study, but we wanted to know what happens to your liver disease or your liver enzymes after vancomycin. And what we see here is that there is a significant reduction in your alkaline phosphatase and your alanine transaminase. So these are 2 liver enzymes that appear to improve or reduce following vancomycin. This does not by any means say that your liver disease is improving. It just means your liver enzymes are dropping. One of the things to keep in mind is that if you improve your colitis, your liver enzymes will improve anyway. So whether this is a function of your colitis improving or for vancomycin, it's unclear at this stage. And it's probably a combination of both. And again, you see that things start to again go up after that 4 week of vancomycin treatment. Bilirubin doesn't really shift. Again, bilirubin being a harder endpoint doesn't really reduce, although most of our patients were not jaundiced. Okay, so what we can conclude from this is vancomycin is leading to clinical remission of PSC IBD. And there's a significant improvement in liver enzymes, whether that is related to vancomycin or related to improvement in colonic disease activity is unclear. So this study was based on trying to understand, not trying to understand whether vancomycin works. We know from the previous data vancomycin works, but what's really interesting is why vancomycin works, because vancomycin is an antibiotic, and we really don't want to be subjecting our patients to long-term courses of antibiotics for reasons we'll discuss later. What's important to understand is why vancomycin is working, because if you can then hone down to those mechanisms, you can then target your treatment to those mechanisms, and maybe even better understand what causes PSC, IBD, or PSC in the first place. So to start off with, well, let's look at the bacteria, the mucosal microbiota. So this is the bacteria that lives on top of the bowel rather than in your stool. So this is as close as you get to the bowel. And what you see is your diversity. So diversity is how many different species of bacteria do you have in your gut. Generally in PSC, IBD, your diversity is low, and even in colitis, your diversity is low compared to healthy controls. So you got lower different types of species. To make it, to describe it very simplistically, you got less different types of bacteria in your bowel if you've got PSC, IBD. In healthy controls, you got far more compared to PSC, IBD. So if someone was designing a study and say, you know what, you're going to go to treatment, if the treatment is going to affect your microbiome, then your diversity should improve if your colitis is going to improve. And that's your usual thinking. But actually what you see with vancomycin is that your diversity gets knocked out even more. So that's your diversity as baseline. It gets knocked out even more. And that's what vancomycin does. It's an antibiotic. Antibiotics kill bacteria in your bowel, right? And they kill bacteria in your gut. So what it's doing is that it's depleting your diversity even more. So vancomycin, you already start off with a lower diversity compared to healthy controls. It knocks it out even more. And again, interestingly, the lower the diversity, the lower your fecal calprotectin. So again, whether this is a cause or effect is an interesting question. Maybe they're two completely different things. Maybe vancomycin is doing something completely different. It's knocking out your diversity, and it's also improving your fecal calprotectin. But there's a paradoxical response, not the response you'd expect to see in someone whose colitis is getting better. And again, what you see here is baselines in blue. This is plotting your gut bacteria in a plot. So if you take all your gut bacteria, try to put it in one dot, this is what that dot looks like. So each of these individual dots is a patient, and their bacteria looks very different at baseline compared to healthy controls, but they all cluster together, and that's key. So if you're better, your bacteria appears to cluster together. These are patients with post vancomycin, and these are patients, I don't know if you can see my arrow, but these are patients prior to the treatment of vancomycin. We can. And they all cluster together, but they're different at these two time points. So again, I'm not going to go too much into detail because I know this is a non-clinical audience, but what you see here generally is a reduction in your vancomycin. What it does is it depletes your good bacteria, right? And it increases some of the bad bacteria. What I mean by this, what I mean by good bacteria, these are bacteria associated with producing certain metabolites that improves your gut health. And what vancomycin does is it depletes that. But despite depleting that, you're getting a clinical response. So what you're seeing is a paradoxical effect. So if this was a patient with ulcerative colitis, a standard ulcerative colitis, their disease will be far worse at this point of time compared to patients with PSC IBD. Again, it states that it's a different disease, mechanisms are different. You're doing what vancomycin is doing is completely paradoxical. And in someone with ulcerative colitis, you'd expect a flare of the disease, but in PSC IBD, you're inducing remission. Again, saying it's something completely different going on here, which makes it a very fascinating study. Again, you see the same thing with calprotectin. I'm going to skip all this. It sort of shows the same data, but it opens a whole host of questions. What exactly is happening here, right? I mean, you're causing a paradoxical response, but your disease is getting better. So is vancomycin knocking out a bacteria, an individual bacteria, and that bacteria is associated with the disease? We don't know. We've never associated PSC with a single bacteria or a constellation of bacteria. We know it's a huge shift in the gut bacteria, but is there a dominant taxa getting knocked out? Or probably more convincingly, is vancomycin knocking out certain metabolic mechanisms, so metabolic mechanisms associated with disease. And that's where all the other data we're currently working on will help shed light on. I'm going to skip all this. This is all basically showing that a lot of your metabolic pathways change following vancomycin, and then now there's a lot of work we're doing in trying to understand what this all means and whether we can hone down to specific metabolic pathways that we think is associated with clinical response to PSC. And one could even argue maybe those metabolic pathways is what causes the underlying disease that you see in PSC IBD. And one of the pathways that comes out is bile acid conjugation, and maybe there's something going on here where bile acid knocking out bile salt hydrolases. These are enzymes that are produced by, or that gut bacteria have, that convert your primary to secondary bile acids. And what vancomycin does, it knocks it out completely. And we see that knocking it out is associated with a reduction of fecal calprotectin. We don't know whether this is a cause or effect, and that's, I think, something we have to keep in mind, because vancomycin knocks out everything, right? And maybe it's just knocking out bile salt hydrolase producing bacteria as well. So whether it's a cause or effect is unclear. But we are looking at this enzyme in greater detail. Okay, so the story so far, vancomycin appears to be associated with improvement in disease activity, in PSC IBD disease activity, as well as in liver enzymes. It causes a paradoxical effect in your gut, not the effect we expected to see, but despite doing that, it appears to improve the disease. So there's something going on here that we don't fully understand, but hopefully the rest of the data, this is only about 20% of the data I've shown, all the rest of the data, the colonic mucosal transcript, the RNA data is coming out, and then the metagenomic, metatranscriptomic data, and the bile acid data will hopefully provide the rest of the story in the coming months. Yeah, I'll end there because I know there'll be lots of questions, and I've got a few more slides here where I'll save that for questions.
Thank you so much, Dr. Quraishi. Please put your questions in the comment section. But as I said, I have had a few questions already. One of the questions I had, I just wondered if you wouldn't mind explaining again about fecal calprotectin and what's the significance of that lowering?
Yeah, so fecal calprotectin is a biomarker that we commonly use to understand disease activity. So we've got several ways of knowing how active someone's colitis or PSC IBD is. The very simple one is your symptoms. So if your symptoms are, if you're going to the toilet 10 times a day with blood in your stool, you don't need any test to tell you that patient has got active colitis or PSC IBD. But let's say your symptoms are under control, and you're going to the toilet once a day, and you're not passing any blood. And is that enough? And for gastroenterologists, no, that's not enough. And we've got different assessments we need to be able to be confident in order to say your colitis is in remission. So fecal calprotectin is a biomarker that will detect mucosal inflammation. That'll tell us how active your colitis is, even if you don't have symptoms. So if your calprotectin is elevated but you're not symptomatic, it means you've got ongoing disease activity, but you're not symptomatic from it as yet. And it often predicts a flare in the future. So if you're not active now, but your calprotectin is elevated, you will have a flare in the future. So what we do is we then try and optimize treatments to normalize the fecal calprotectin to reduce the risk of a flare happening. So often with patients with PSC, you may not have many symptoms, but you'll have a lot of disease on the inside. And we're trying to address that side of things as well. And of course, the gold standard in understanding someone's PSC IBD is by doing invasive investigations like a colonoscopy, sigmoidoscopy, scans, capsule endoscopy. We don't often do that unless we absolutely need to, apart from usual screening, annual surveillance colonoscopies. So often we can get enough information just through a fecal calprotectin. So fecal calprotectin is a very sensitive tool in trying to understand disease activity in conjunction with symptoms. And normalization of fecal calprotectin is often goes hand in hand with clinical disease activity states.
Okay, thank you very much for that. I've got a question here. As we know that in the US they use vancomycin more regularly than in this country. The question is, what are the benefits of comparatively low dosage of vancomycin? And I know you mentioned 125 milligrams. I think that's what you mentioned, QDS. And the questioner says, in the USA, they use much higher doses. So why is that?
Yeah, I mean it's not entirely clear. So whilst vancomycin has got low bioavailability, what I mean by that is if you take someone's blood after you give 4 weeks of vancomycin, you'll see very little vancomycin in the blood because it doesn't get absorbed. It stays in the gut, comes out in your stool. If it's after it does, whatever it needs, it does in the gut, change the bacteria, change certain pathways. That's based on the standard dosing. So vancomycin is currently licensed at that dose for treatment of certain infections like C. difficile infection. The higher doses are not licensed, and we don't know whether the bioavailability goes up at higher dosing. It may do. But once you break through a threshold, maybe you'll have detectable vancomycin in the blood. Now, vancomycin is not without problems, and that's one of the things that I wanted to discuss. It's great that it works for PSC IBD, but the question is whether there are any side effect risks or adverse events to it. And one of the biggest problems we have in the current era of antibiotics is antimicrobial resistance, where you start producing, where your gut bacteria starts to adapt to antibiotics and starts developing resistance genes that then get shared amongst the bacterial community. So then when you actually need vancomycin, it is ineffective to treat that infection. And that's a worry. And we've seen that in a subgroup of patients we've tested in PSC vancomycin, where there's a rapid emergence of vancomycin resistance enterococcus that often stays with them even after you stop the vancomycin.
Right.
So there are a couple of reasons why we don't use vancomycin routinely in this country, because the standard treatments appear to be effective in treating PSC IBD. So the immunosuppressive treatments that we give is effective, but we are well aware that there is an antibiotic option, and we know that often patients in the States and in Europe will be on antibiotics to treat the PSC IBD even before they go on to immunosuppressive treatments. We've got good long-term safety data with immunosuppressive agents. We don't have that data with vancomycin, because a lot of the patients that get put on vancomycin in the States, they are on it, but there's no long-term safety assessments around, for example, antimicrobial resistance. There's no data out there to say, right, 10 years of vancomycin, this is the resistance pool you've generated, and what happens if you have that resistance pool when you get an infection? Are you able to clear out that infection as effectively as anyone else? We also don't know we know that IV vancomycin is associated with risks, not associated with oral vancomycin. And these are risks associated with toxicity to the kidneys, toxicity to the ears, and whether higher doses of vancomycin, oral vancomycin, allows that increase in your bioavailability for you to have the same risks as IV vancomycin is unclear. No one's in that study. Right now in this country, vancomycin is only licensed at 125 milligrams QDS, so 4 times a day. So which is why we can't, we would be, and it seems to work even at that dose. So there was no reason for us to push the dose higher, and we'd have to go to MHRA, so our regulatory body, to gather approvals for that, and then we'd have to do all the safety testing to say higher doses are safe when it comes to bioavailability, which we don't have as yet.
Okay, thanks for that. So we seem to be able to manipulate the gut microbiome with antibiotics, but is the same true for probiotics and prebiotics? Can they also manipulate the microbiome and maybe help to treat PSC?
Yeah, and that's a very good question. I think so. There are many ways that you can change the microbiome. Vancomycin is what we call a suppractative therapy. So you're taking something away because it's an antibiotic. And there are many other suppractative therapies. You may have heard of bacteriophages. These are viruses that go and target and kill certain bacteria. They're very targeted therapies. Probiotics are modulatory therapies. So they don't add anything to it, unlike fecal microbiome transplant, where you're adding something to it. Probiotics are meant to modulate your existing gut bacteria. The data out there for probiotics is very weak. It's not based on solid science. It's based on what we think works in mice, and it's not based on, and the clinical trials that have been done in colitis have not been very effective, which is why probiotics have never taken off for colitis. There seems to be some role in IBS, so irritable bowel syndrome, completely different condition, in helping treating some of the functional symptoms like bloating, abdominal discomfort. But generally, it's ineffective. We don't prescribe probiotics. We don't necessarily recommend probiotics. If patients want to try it, we don't discourage them. We say, well, that's fine, because there's good safety data for a lot of these probiotics, but we don't say it's effective. And certainly, if someone's got active colitis, we wouldn't be using probiotics to treat the colitis. There are other treatments coming out that you will hear of soon. There's a new era of something called live biotherapeutics or next generation probiotics, which is a different form of probiotics. So the older probiotics are approved on the basis that they are food supplements. So they don't need to show that you can use probiotics to treat a condition. That's why you can find them stocked in Holland & Barrett's or in Asda, and you can take it. Live biotherapeutics are like probiotics, but they are licensed for the treatment of specific conditions. And you may have heard of a probiotic or a live biotherapeutic product getting approved for the treatment of prevention of C. diff infection only a couple of weeks ago. So that was the first novel next generation microbial therapy to get approved by FDA for the treatment of a specific condition. So there are lots of other treatments currently being explored for the treatment of ulcerative colitis. So these are bacterial strains that are pulled together in a consortia, and they're currently being explored in clinical trials. So there may be something there for PSC IBD in the future that may come out of FMT trials as a novel treatment. But the probiotics and certainly prebiotics, there doesn't seem to be much of a role for the treatment of PSC IBD, but we wouldn't necessarily discourage patients from trying it if they feel that that they might find a benefit to it.
Okay, thank you very much for that. Question here from Australia, actually, from a patient from Australia, I think a patient or a family member. Have you noticed any difference between vancomycin powder vials diluted or tablets? Also, is there any brand difference?
No, so we use the tablets, and that's what we had in our pharmacy as routine that we use for C. diff. It seems to work. We haven't explored different formulations. We know that, there have been some work done in the States to show that branding is important and formulations are important, but seems to work in our study. The generic, so these are generic vancomycin tablets that we use for treatment of C. diff, and it's the same tablets that we've used.
Thank you for that. So I know that you mentioned that long-term vancomycin is unclear at this moment in time, but this question relates to having somebody on that long-term, I think. So it's once a person is has good stable results, would you keep them on that, or then would you reduce the dose, or how would it work? How do you foresee that?
So that's an excellent question. If someone says they know the answer to that, then they're lying. I think it's all empirical. So we had a discussion with our American colleagues as well. So in America, they do it slightly differently. In America, they put patients on vancomycin and they keep them on it at a low dose or the standard dose long term. And they're well aware of the risks associated with that. And the risks are antimicrobial resistance. We don't know the long-term side effects of long-term vancomycin, and certainly unlicensed. We've got very safe and effective immunosuppressive therapy where we know the long-term profiles of these treatments. There are registries of these drugs, and we know what the long-term outcomes are, both clinical outcomes as well as adverse events, and we can monitor for those. We can't for vancomycin. We don't see any data coming out to show these are these patients have had vancomycin resistance genes, and when they get an infection, these are the outcomes. None of that data is out there because no one's looking at it. It's not because there's absence of the data, it's because no one's actually studying it. Whereas all this data is being studied with immunosuppressive agents. The way we do it here is since we started using vancomycin recently in a select cohort of patients who are refractory to immunosuppressive treatment, so they've failed everything, their pre-colectomy, we can use it on what we call a specials license, or a license where we can, because it's unlicensed currently for PSC IBD. So we can say, well, they failed everything, They're now pre-colectomy. They're going to have surgery. Let's try vancomycin. And what we do is we use it a bit like steroids. We give it alongside a biologic, and we see how it works. If they enter clinical remission, we take them off it and we watch and see what happens. If they then start to relapse, then we have discussion again with the patient to say, do you want vancomycin? Do you want steroids? Do you want to optimize or switch to a newer agent, if there's a newer agent available, immunosuppressive agent? So we don't have many patients on long-term vancomycin. We use it sporadically to treat flares. I think that's a middle ground. The evidence base for this is zero, right? So this is all empirical, and there is no evidence base for using long-term vancomycin, and there is no evidence base for using sporadic vancomycin. It seems to work either way, and this is anecdotal, but until we see a good, until we see decent data coming out for safety profiles of long-term vancomycin, I think this is probably the lesser of two evils. Yeah.
Thank you. So I know you're not a liver specialist, but we do have a question here about, can you expand on the difference between liver enzymes and liver out versus liver outcomes that you mentioned?
Yep. So one of the important things with PSC, as we all know, is firstly to improve liver, well, is to improve liver outcomes. And liver outcomes are, I mean, the hard outcomes are your risk for transplant, and how long can you delay a transplant, and then there is mortality. Those are the two hard liver endpoints, and it's about vancomycin being shown to improve liver outcomes. So risk of transplant, 5-year transplant-free survival, for example, is one of the outcomes we look at. So what's your risk of having a transplant at the end of 5 years? Is it going to be any different to someone who's not on vancomycin? And that is the liver outcome of interest that a lot of studies would, that explore treatments for vancomycin would look at. Now, that is a long-term study. You're looking at 5-year outcomes, so you'd expect to have long-term follow-ups in these patients. What we see is liver enzymes, right? So we see an improvement in liver alkaline phosphatase and liver alanine transaminase. Does that mean that your liver outcomes long-term will correlate the same? So if you improve someone's ALP, does it mean that your 5-year transplant-free survival is going to be the same as someone whose liver enzymes don't shift? That's a no, we don't know that. So liver enzymes don't correlate necessarily very well with long-term outcomes. So all we see is an improvement in liver enzymes. We can't really, extrapolate and say, well, this all equates to improvement in 5-year survival, because that link has never been shown, and certainly has not been shown with vancomycin either to this date. Yeah.
This question might be related to what you just said, so just let me know if it was. Some patients report remarkable improvement in quality of life. I presume they mean by taking vancomycin, not all, but many, and improvement on liver imaging. Can you hypothesize on how your data might affect liver health?
Yeah, so we notice a lot of patients, especially in our cohort, notice an improvement in fatigue and in pruritus scores. So it's itching, two common features of PSC. Whether that's because of improvement in bile acid profiles, and we know both of these symptoms correlate with your serum bile acids, is unclear, and a lot of the hopefully some of the data that we'll be generating from this work will tell us how vancomycin improves MRI imaging. Unclear. Again, I'm not a liver specialist, but once your fibrosis is set in, the question is whether it'll prevent further progression of liver fibrosis. Is something yet to be answered. I think, and maybe there's anecdotal evidence out there from patients, which is really useful, but you need a long-term study. The question is whether there is a role for long-term doing a study with long-term vancomycin. Is there? The big question is, should we be doing a clinical trial with exploring long-term outcomes with vancomycin, both looking at clinical outcomes and looking at the adverse events in 5 years? Yes, maybe. Yeah, I think, and then there are a couple of studies, there are a couple of trials now currently embarking in the next year or so in trying to understand long-term efficacy and safety of vancomycin. But the other more important question is, what does vancomycin do that improves your colonic health and maybe liver health? And maybe it's about understanding those mechanisms that we then target with new treatments. And that's what we're trying to do. because we know vancomycin, I mean, you can do all the studies you want. We know that there are risks associated with long-term vancomycin use. And maybe the better way of doing is try to understand what vancomycin does, and then hone down on those mechanisms and target those mechanisms directly with different pharmaceutical methods.
Okay, thank you. So the next question, the trial shows gradual return of IBD post vancomycin intervention. Is there a recommended vancomycin course of treatment or frequency for further intervention with patients who have relapsed?
Yeah, so as I said, I mean, it's all empirical. There is no fixed data. We get 4 weeks of vancomycin. Why we get 4 weeks as opposed to 8 weeks, for example, is again empirical. We knew we couldn't get away with 8 weeks with our regulatory bodies. 4 weeks is probably as much data there was in literature for C. diff. So, you know, in C. diff, often we have to treat patients for 4 weeks, and we know up to 4 weeks the data for safety is there. The data beyond 4 weeks, you know, solid, robust data is not there around safety, which is why we chose 4 weeks. So a few of these patients ended up relapsing at 4 weeks. In these patients, we had a discussion with them. We said there are other licensed therapies now, and there have been a few more licensed therapies for ulcerative colitis that have come out since then, and you know, and with good data, safety data and efficacy data. Do you want to use that, or we can always have a discussion about vancomycin? Some of these patients opted for vancomycin, so then we gave them another course of vancomycin. A lot of them have stayed in remission since then. Some of them have relapsed, and then in those patients we've put on again slightly longer term vancomycin. But we will revisit. So when we say longer term, we said 3 months. At 3 months, we then have a discussion again to say, right, if you had a full 4 months or 5 months of vancomycin, we don't know the long-term effects. We're monitoring you as closely as we can. There are other treatments available. Do you want to try something else at this point? And then we can always go back to vancomycin if you fail. And I think we have to have that, you know, skepticism, and you know, we have to be very cautious when we use antibiotics for treatment of conditions. And whilst it's effective, there are other effective treatments out there that are, you know, safe. They're low risk. In absence of, you know, safety there for long-term vancomycin use that we need to discuss with our patients.
Okay, thanks for that. Question here, are there any promising results from the vancomycin clinical trials at the Mayo Clinic? I don't know if you know anything about that. You could tell us about that.
Yeah, there are a couple of trials that are currently in progress. None of them have been published yet, so or presented in abstract format. But hopefully we'll know of that in the coming year, I guess. Yeah.
Okay. I have a few other questions. I think you've possibly answered most of them through answering other questions, but I'll just ask a couple more. Question here, is vancomycin the same as urso?
No, completely different. Vancomycin is an oral antibiotic. Ursodeoxycholic acid is a synthetic bile acid. Yeah. So works differently. They probably work on similar mechanisms, but they work differently.
Right.
They're different drugs.
Thank you. I've got a couple of PSC questions.
Yeah.
I don't know if you want to, want me to ask, is that all right to ask you those?
Yeah.
Okay, I'll ask you these two then. The questioner was diagnosed with PSC a little over 2 years ago. I now find that I experience cold shivers that can affect me at any time of the day. My whole body is cold and it can stay with me for some time. Is this PSC related? Do you know?
Yeah, so if someone gets cold shivers in background PSC, one of the things that we'd be concerned about is making sure they're not having an infection. So cold shivers can be a sign of an infection. So it's sometimes what we call rigors. So yeah, you want to make sure you're assessed by a physician or your doctor. You know, have your temperature checked. Make sure you're not developing cholangitis or subclinical infection in your liver. So yeah, I mean, I think it's something that you'd want to see a doctor about and get assessed.
Okay, thanks for that. Another question. I have recently been diagnosed with PSC 6 months ago and have had a DEXA scan as a baseline test. I'm interested to know why PSC affects bone density and how bone mass is reduced over time.
Yeah, so it's an interesting question. I mean, I don't know the exact answer to that. Maybe there is a scientific explanation to it, but a lot inflammatory conditions are associated with osteopenia, which is basically thinning of the bones.
Yeah.
That's because of the way these inflammatory cytokines interfere with bone formation. And maybe the mechanisms are associated based on cytokines. Whether there's anything to do with absorption of calcium from the gut and resorption of bone profiles directly related to PSC, I don't know.
Okay. Question here. Hello, everyone. What is the main reason that not everyone responds to OV treatment?
What's the main reason?
Mhm.
That's the $1 million question. And I think that's what we're trying to answer. Yeah. So whilst we say everyone, there's only 15 patients that we've looked at and 15 patients responded. It's not a clinical trial. In a clinical trial, it'll be powered to look at that effect. So if we had 30 patients, for example, maybe only 60% will respond, maybe 50%. Maybe we got lucky with our 15. We don't know. It is unblinded as well. So, there is no blinding, there's no placebo control. So it's not a standard clinical trial. It's an observational study for all intents and purposes. So I'm sure everyone on this call knows the blinding is. So if you're doing a proper randomized control trial study with vancomycin in a group of patients with PSC and PSC IBD, what you do is you'd have a placebo and you'd have the actual vancomycin, and neither the patient or the doctor giving it will know what you're giving. So the only person who's blinded is behind the scenes, who's unblinded is behind the scenes, who's dishing out the pills, for example, but the doctor doesn't know what they're giving because it's all covered, and neither does the patient know what they're giving. So we can't be biased in our assessment, because one can introduce bias easily to say, well, I'm expecting to get better because I've got the active treatment, and the physician is also expecting the patient to get better because they've had the active treatment. But if neither you or I know what treatment you're having, we make a completely unbiased call as to what the disease is doing. That's how you do clinical trials, and that sort of clinical trial will give us a real answer as to how effective vancomycin is in treating PSC IBD. So yeah, 15 patients got better, but there's a lot of bias in here, I'm sure, and although we've used objective assessments like fecal calprotectin, which you can't fake because it is an objective test, you still want to do this, properly powered, so you have the right number of patients to answer that clinical outcome, and you'll have blinding in there.
I think we will sort of wind up now, but I've got a couple of questions about the next steps for the trial, for the study. So what are the next steps, and is there a predicted published date for the study at this stage?
Yeah, so we're just finishing off on the metagenomics, so looking at the detailed analysis of gut bacteria and what they're doing following before and after vancomycin. We also we've done a couple of other. We're also finally doing the bile acid profiling being done by my colleague Ben Mullish in London. So we'll have all that hopefully in the next 2 to 3 months. And we're looking at writing it up, analyzing data and writing it up in the next 6 months. So before the end of the year, hopefully, we'll have the data out in public release. Yeah, but I'm more than happy to present it again once we got the full data at another PSC support meeting.
Brilliant. Thank you very much. There's a couple of questions just come in actually that I didn't spot. If you don't mind, we do have a couple of minutes. Are there any differences in pediatric population, in the pediatric populations? Has there been any trials?
Yeah, there have been observational studies looking at vancomycin in pediatric population, and again, the data is a bit of hit and miss. Again, you're looking at long-term outcomes here, and the long-term outcomes don't appear to change, and these are the hard endpoints. From a PSC IBD point of view, so which is what I'm an IBDologist. Again, there are not that many studies out there anyway, looking at response to IBD, but the studies out there are promising. So it shows that PSC IBD gets better, but the studies looking at the PSC side of things don't appear necessarily to show. But these are observational studies; they're not fully powered, and they don't really, they're not powered to ask that question necessarily. Yeah.
Okay, a couple more because we've got 5 minutes and we've had these come in. So thank you very much for this presentation. Do you think you'll possibly test the VRE gene expression on these patients in the future, those that are not taking vancomycin now?
So a group of patients who are not taking vancomycin. So VRE is, it's a common strain that that you can carry even if you've not been exposed to vancomycin. It spreads just like any bacteria, person-to-person contact, which is why, if there's a VRE incident in a hospital, that bay gets closed so that there's no spread between patients, because patients can acquire VRE through close contact. What we've shown is what happens after vancomycin, to VRE emergence. So patients who were VRE negative before the study, they have VRE come on after the study. How that reflects a standard VRE pool in non-exposed patients, I don't know. I think those are questions that will need to be answered in studies looking at vancomycin for clinical use. I'm not sure whether the RCTs that are currently doing that, exploring vancomycin for clinical use, are looking at VRE, but yeah, I think that's something that we need to explore.
That's great. Thank you so much for joining us today. I think we'll wrap it up there, but it's been such an interesting and exciting study, and to hear about the study. So thank you very much, Dr. Quraishi, for joining us. And I think I am talking on behalf of everybody that's joined us today in thanking you for that. And I do hope everyone, thanks very much for all your questions. And I do hope that we've been able to answer, well, I've not, Dr. Quraishi has been able to answer your questions. The next session we have, the next Ask the Expert, is on the 27th of June. So a month's time at 7 p.m. in the evening. We're trying to do these different times of the day, different days, so we give everybody a chance to come on the Ask the Expert sessions. Dr. Emma Culver will be our expert on that day, and she will be speaking on research and the most up-to-date research outcomes and what's happening in the research world following EASL, which is the European Association for the Study of the Liver, which is taking place in June in Vienna. So just after that's taken place, Dr. Emma Culver will come on and tell us about the new research, the research that's being uncovered and is being investigated by at that meeting, or from that meeting. So I hope you'll all join us then. And Dr. Quraishi, thank you so much, and enjoy the rest of your afternoon, everyone.
Thank you very much. Thanks for the invitation.
Bye-bye. Thank you.
Bye.